Welcome, everyone. Today, we're going to explore one of the most important tools in clinical practice, the mental status exam. The MSE helps us understand a client's emotional, cognitive, and behavioral functioning at the time of a session. It's essentially a structured way of observing and describing what's happening in the moment. You already conduct MSEs every day, anytime you note how a client looks, speaks, or interacts. The goal today is to help you document those observations with clarity and confidence. By the end of this training, you'll be able to describe clients using objective, professional, and clinically meaningful language. Today, our training objectives are to define the purpose of structure of the MSE, identify and describe key domains of the MSE with special focus on thought process, thought content, insight, and judgment, document observations using clear, objective language, differentiate between normal and abnormal findings, practice interpreting MSE observations through interactive exercises. So, as we go through, think about which areas you feel strong in and which you'd like more practice with. Now, what is the MSE? Well, it is a structured assessment of a client's current mental state. It reflects how the person is functioning emotionally, cognitively, and behaviorally right now. We gather this information through observation, conversation, and interaction. Think of it like taking a mental snapshot. It doesn't tell us who the client is overall, but it tells us what we're seeing in this moment. Let's pause for a quick discussion. What are some cues you notice about a client's mental state during your sessions? Maybe tone of voice, energy, their posture, their focus. Pause now. Why does the MSE matter? Well, for several reasons. First, it forms the foundation for diagnosis and treatment planning. What we observe helps guide interventions and identify needs. Second, it supports clinical documentation. MSE notes demonstrate your professionalism, objectivity, and awareness or risk of safety issues. Third, it's required in psychosocial assessments, progress notes, and intake evaluations. And finally, it reflects your clinical judgment and observation skills. Here's a question for you. How can a well-written MSE help another clinician who reviews your notes? The MSE is divided into several domains, each focusing on a different area of mental functioning: appearance and behavior, speech, mood and affect, thought process, thought content, perception, cognition, insight, and judgment. Each of these domains gives us unique information about how the client presents in the moment. Today, we'll focus most on thought process, thought content, insight, and judgment, since these require the most clinical interpretation. Now, let's start with thought process, which describes how a client's thoughts are organized, connected, and expressed. It's not about what they think, that's thought content, but how those ideas flow. Ask yourself, are their thoughts logical and goal-directed? Or are they disorganized, tangential, or hard to follow? The goal is to describe form and flow, not to interpret or label. You'll see examples of that next. Now, here's a breakdown of common thought process patterns. Normal, logical or coherent. These thoughts are organized and make sense in context. Circumstantial. The client gives excessive detail but eventually gets to the point. Tangential. Goes off topic and never returns to the question. Loose associations. Ideas jump from one topic to another without clear connections. Flight of ideas. Rapid topic changes, common in mania. Thought blocking. The client suddenly stops mid-sentence or loses their train of thought. Perseveration, repetition of words or ideas that are no longer relevant. Neologisms, invented words with personal meaning. Clang associations, speech based on rhyme or sound rather than meaning. Word salad, completely incoherent mixture of words. When documenting, focus on what you observe. For example, instead of saying, client was manic, write, speech rapid and pressured with frequent topic shifts. Now, let's practice identifying thought processes. I'll read a short client statement, and I want you to name the thought process that you hear. My boss yelled at me, and I thought about quitting. And then I thought about when I was in high school. That reminds me of football games. That's tangential. They never return to the main topic. Here's another. I was thinking about the store. Stores have lights, and lights are bright, and brightness means hope. I am so hopeful. That's flight of ideas, rapid shifts and loosely connected. See how listening closely can tell you so much about how someone's thoughts are functioning? Next is thought content, which is what the person is thinking about, the beliefs, fears, or themes that fill their thoughts. This could include delusions, obsessions, phobias, or suicidal or homicidal ideation. For example, if a client says, my neighbor planted a device in my wall, that's delusional thought content. If they say, I can't stop thinking about germs, that's an obsession. Our goal is not to challenge the belief in that moment. It is to note and describe it accurately. When you assess thought content, listen for recurring patterns, preoccupations, or unusual beliefs. Common thought content abnormalities. Here are some of the most common types you'll encounter. Delusions, fixed false beliefs. The FBI is watching me. Obsessions, intrusive unwanted thoughts. I can't stop thinking I'll hurt someone. Phobias, irrational fears. I can't go outside because of the germs. Preoccupations, repetitive focus on a theme. Constant worry about finances. Suicidal ideation, thoughts of self-harm or I don't want to live anymore. Homicidal ideation, thoughts of harming others. Sometimes I want to hurt him. Sometimes I want to punish others. Now, I think it's important that we remember thought content is what they are thinking about. Thought process is how those thoughts are organized. When you read these 3 examples, what do you think? Insight is a client's awareness and understanding of their mental health and behaviors. You are assessing whether they recognize what's happening and understanding how it affects their life. For example, good insight. I know my anxiety makes me overthink things. Fair insight. I have some anger issues, but it's because people provoke me. Poor insight. There's nothing wrong with me. Everyone else needs to change. Now, clients often fall somewhere in between. Our job is to describe what we observe and what they express. Do they recognize their symptoms or challenges? Do they understand the causes or triggers? And can they connect thoughts and behavior to real-world outcomes? Now, you can think of insight as a spectrum. Good recognizes those symptoms and seeks help. Fair acknowledges some problems but externalizes the blame. Limited, minimally aware or avoids connection between behavior and consequences. Poor, denies illness or need for treatment. Absent, delusional or lacks awareness entirely. This is a key for treatment planning. Insight often predicts how open a client will be to feedback, coping strategies, or change. Now, judgment is about decision making and the ability to anticipate consequences. You're observing whether clients make safe, realistic choices. Good judgment seeks help when distressed. Poor judgment drives intoxicated or ignores medical advice. With good judgment, if I feel overwhelmed, I'm going to call a friend or my therapist or someone to talk to. But with poor judgment, I drove home after 3 drinks because I felt fine. You can assess judgment with scenario-based questions like, what would you do if you found a stamped addressed envelope on the ground? Or, what would you do if you felt unsafe at night? Their answers reveal how they problem solve and evaluate outcomes. Insight and judgment often go hand in hand, but measure 2 different things. Insight is self-awareness, recognizing the problem. Reflection. Judgment is decision-making, how they act on that awareness, the action. For example, a client may say, I know drinking makes my depression worse. Good insight. But still continue to drink daily? Poor judgment. In documentation, always describe both. For example, insight fair, acknowledges anxiety but minimizes impact. Judgment intact, seeks support appropriately. Now, let's do an interactive scenario. Alex comes to you and says, I only hear voices because my neighbors installed cameras in my vents. I don't think therapy can help me. How would you rate Alex's insight? What might his judgment look like based on this statement? Pause the video here. When documenting your MSE, describe what you see, not what you assume. Speech rapid and pressured, client difficult to interrupt. That is correct. Client was manic and annoying. That is subjective language. Insight limited, minimizes symptoms and externalizes blame. That is objective. Client refuses to admit they are sick. That is subjective. We need to stick to behavioral descriptors instead of emotional labels. This keeps your notes professional and protects you legally. Here's a simple MSE structure you can use in your notes. This format ensures you're covering every major domain consistently. Now to close, let's summarize what we've learned. The MSE is a cornerstone of clinical observation. Always observe before interpreting. Use behavioral descriptors, not emotional labels or assumptions. Integrate your findings into assessment, treatment planning, and documentation. Now, for a final reflection, what is one domain that you feel more confident assessing after today's training? Now, thank you so much for doing this work with me today. The more we practice observing without judgment, the more precise and compassionate our clinical work becomes.